is Shelley Meharry. I'm President and CEO of the Community Foundation of Johnson County. I want to thank you all for coming out on this 87th day of January. It does feel like it's a very long, cold month, but we do appreciate the extra effort to get here this afternoon. The Community Foundation has begun holding a series of community conversations, bringing together our local experts on topics that are important to our community. The role of the Community Foundation is to really be a convener. We're really turning over the stage to those who are working most closely to the topics of interest in our community. We have held 2 other community conversations so far. We held one on affordable housing in June 2024 and childcare in September of 2024 as well. We know the topics that we are discussing are really big, and we are just skimming the surface. But our hope is that if we can bring our community a little closer to the people and organizations that are working in this space, that you can make a connection and be a little bit closer to their work as well. Before I begin, I would like to let everyone know that we are already planning our next community conversation. It will take place on April 22nd from 5 to 6:30. This time we're going to go across town and visit our friends at the Coralville Public Library for the topic of immigrant and refugee support. And I think everyone's heart feels like that's a timely conversation for our community right now as well. And before we begin, I'd like to take a quick moment and share a special thanks to a team member of mine, Ellie Moore, who's our Vice President of Community Impact and Engagement. Ellie has been instrumental in bringing together our panel of experts, and we thank her and our experts for joining us this afternoon. And as we jump in, I also want to make everyone aware that we're doing our community Q&A a little bit different than we have before. We ask you, if you have a question that you have for the panel or any other discussion topic, that you write it down on a card, and we will be collecting those. This will give anyone a chance to ask a question that they might not feel comfortable asking publicly in front of everyone, and we can curate those for you that way. So those cards and some pens are also available at the back of the room if you didn't have a chance to grab those as well. So today's program, we will have a wonderful overview of mental health in Johnson County from our subject matter expert, Laura Semprini, with the National Alliance on Mental Health. You can see our wonderful panel of some additional local mental health experts as well, and then time for Q&A. So I'm going to jump in and welcome Laura as our presentation to get us started this evening. Laura Semprini is a remote peer support coordinator at Our Place Peer Recovery Center and a program of the National Alliance on Mental Illness, Johnson County. You have to forgive me, my readers are sort of a new thing for me, and I can't live without them. They're migrating, they're multiplying all over my home, as they do, right? You get lots of readers. But you'll have to forgive me. I'm getting used to this. They're helping very much, but if I fumble here, I apologize. So she began working at Our Place as a peer support specialist in 2019 and started coordinating the remote program in 2022. In addition to this role, she also writes grants and oversees new programming. She teaches yoga at the GuideLink Access Center in Iowa City and facilitates a virtual support group of peer support professionals in Iowa. This past year, she began serving on the governing board of mental health/disability services of the East Central region. In 2010, she received her bachelor's degree in economics and international business from the University of Iowa, and shortly thereafter completed a master's degree in nonprofit development from the London School of Economics and Political Science. From 2013 to 2015, she was the Director of Development for Horizons Social Services Agency in Cedar Rapids, and then lived abroad with her husband serving in the Peace Corps in the Republic of Fiji from 2015 to 2017, which was probably warm, I would imagine.
Much warmer.
Much warmer. Much warmer. Well, welcome, Laura. Thank you for being our presentation for this afternoon. We sure welcome.
All right, thank you very much for that introduction. Again, my name is Laura Semprini, and I'm with Our Place Peer Recovery Center, which is a program of NAMI Johnson County. I'm really encouraged to see the turnout today. It's great to see all of you here. So just to jump right in here, if you are comfortable, I would like to know by a raise of hands how many of you have a connection to mental illness, either yourself or someone that you know. Yeah, so pretty much everyone's hand is up. I am not surprised you are all here, but also because 1 in 5 adults experience mental illness each year. So that means millions of Americans are impacted by mental illness. I myself have a personal connection to this issue. These pictures you see here were taken in 2018. Shortly after my first daughter was born, I was diagnosed with bipolar disorder. It was an extremely difficult time for me. Thankfully, I had a supportive family and really supportive group of friends who helped me through it every step of the way. But many of the services I will mention here in my presentation that we will talk about throughout the evening, I have received myself. I have gone through that dark path and thankfully came out on the other side, and now have the opportunity in my work working for NAMI to help others who are on their recovery journey. So just to highlight a few statistics here, these were all gathered by NAMI National in 2021. I already mentioned that one at the top. I know the text is maybe a little small, so hopefully you can see it, but I'll highlight a couple out loud. So I already mentioned 1 in 5 U.S. adults experience mental illness each year. Some of these stats are specific to our state of Iowa. So you'll see the first one highlighted there, 42% of adults reported symptoms in 2021 of anxiety or depression. And on the youth side, 1 in 6 youth, so that's ages 6 to 17, experience a mental health disorder each year. A couple more here, and that is 1 in 5 people experiencing homelessness live with serious mental illness. And 1 in 4 people with a serious mental illness have been arrested sometime in their lifetime. So we'll talk a little bit more about the revolving door is what we call it. So people circulating through hospital, jail, homeless shelters, etc. So I just want to stress the importance of ending the stigma, which is talked about a lot in this day and age, but I just want to acknowledge that all of you, by being here, you are helping to end the stigma against mental health. So just showing up and being open to having these tough conversations, that is what you're doing right now. And so I just want to acknowledge that and thank you for being here to listen and participate. So as we all know, stigma can be a huge barrier to care, and I wanted to just list here some other barriers to care, which one of our panelists will go into more detail later. But some of them listed here are cost, transportation, accessibility, faith or cultural beliefs, distrust of the medical system, maybe the belief that getting help is just too complicated to navigate all of the different avenues, belief that getting help is a sign of weakness, or anosognosia, which is a long word that means when someone is unable to perceive or know their own illness. So this, as you can imagine, is a huge barrier to care, because if the person is sick and doesn't think they need help, they don't think they need support, they're not going to go and pursue treatment. So I'll mention that a little bit later in the presentation, but because it's such a long word, I wanted to explain what that meant. So when we talk about treatment options here, I broke them down into categories. So the first one that I'll talk about are inpatient services. So these are psychiatric units in the hospital. Here in town, we have the University of Iowa hospitals and clinics with inpatient units for adults and children. And then the concept of an access center, which we do have here in town. I'm just curious, how many of you know about the concept of an access center or are familiar with GuideLink here in town? Okay, a lot of hands. That's awesome. I'm really glad to see that because word is still getting out and it's a fairly new concept for people to get a grasp on. But it's an alternative to inpatient psychiatric care. So it is residential, it is voluntary, but people can stay the night and get 24/7 access to mental health crisis and substance use care. So our executive director of GuideLink is here on the panel. She will talk more later on the panel, but I just wanted to explain what an access center is in general in case you see that and don't know what it is. So we're probably all familiar with outpatient services. So these are things like going to talk therapy, whether in someone's office or via telehealth, going to a psychiatry appointment for medication management with a doctor or an advanced nurse practitioner. And then we have community-based services, which I will kind of break down there are a lot, so I won't be able to touch on all of them, but just services that are based in the community that get people out and about. Okay, I'm making you all raise your hands a lot, I feel like, but how many of you know about 988? Okay, I love this. You guys, I don't even need to be up here presenting, you know everything. So 988, for those of you who don't know, it's the 911 equivalent for a mental health crisis. So this started over 2 years ago. You can text or call this number, and there's a local dispatch. Here we have Community Crisis Services doing that. Our representative Drew is on the panel. He'll talk more about this in more detail. But basically when people call this number, they'll get either a local dispatch or get connected to some sort of referral to help de-escalate the crisis and get help immediately. So yeah, I think word is really getting out. There are still people who don't know about it. And so I think it's important to mention this to really anyone because you never know who might be needing crisis support. So another bit of information here about community crisis services, and I don't want to take over too much of what Drew is going to talk about, but community also does mobile crisis outreach. So the way this would work, if someone does call 988, they may be connected to have a mobile crisis dispatch. So these are counselors that dispatch to homes, schools, businesses, public spaces, really anywhere that someone needs crisis support. It's 24/7 crisis de-escalation, providing emotional support, help with referrals. So sometimes the crisis might be resolved over the phone, or the counselors will be dispatched and go in person to help that individual. They may, if it's appropriate, take them to the hospital, to GuideLink, wherever they find the most appropriate care. It's pretty awesome. The response time is 30 minutes or less. Really incredible service. And I mentioned here they'll really go anywhere. They'll also go to schools because there's crisis support for youth as well here. Okay, at the University of Iowa hospitals and clinics, I mentioned this earlier, but of course there are inpatient units. They take voluntary and involuntary committals. And right now there are 15 beds reserved for children and youth. There's also a unit called the CSU, the Crisis Stabilization Unit. So this is also residential care, but it's designed for shorter stays, so more like 2 days. I have had the opportunity to visit this unit recently because just within the last month, they moved to a new space within the University of Iowa hospitals, but the original spot opened in 2018. I'll talk a little bit more in a bit about the services that we offer at our place in terms of peer support. But we have recently started sending peer support specialists onto the CSU unit to talk about our peer support services and offer peer support for individuals on the unit. Shout out to Leanne, who's here in the audience, one of our staff members who has been going into the hospital very recently, I mean, just within the last few weeks. And so we're excited to have that partnership and to be working with people on the unit who need some extra support. At the University of Iowa, there's also the partial hospitalization program, which is a day program, so people do not stay the night at the hospital, but they go pretty much all day and get that extra support with daily interactions with providers, nurses, therapists, psychiatrists. They have several tracks, so there's the mood disorder track, eating disorder track, and then dual diagnosis track, which is for someone with a mental health condition as well as a co-occurring substance use disorder. Our peer support specialists have also been going into the partial hospitalization program at the university to lead groups and share their recovery story, which for those of you who aren't familiar with peer support, I'll talk about that in a little more detail as we get going here and I talk about the services we provide at our place. So at the University of Iowa, there's also the intensive outpatient program, which is similar to the partial program. It's just fewer hours. So it also meets during the day and people get to sleep at their own home. Okay, back to GuideLink Access Center. So Abbey will talk in more detail on the panel. But this is our local access center in Iowa City. It's on the south side of town by the waterfront Hy-Vee. It is immediate access to mental health and substance use care for adults. It is all voluntary, residential crisis stabilization, and medically monitored detox and a sobering unit. So although it is residential and an alternative to inpatient care, it's much different than a hospital in that it's a much less restrictive environment. People get their own rooms. They're allowed to keep their cell phones. There's opportunity to participate in various programming. It was mentioned I teach yoga there on Thursdays. It's really a fantastic environment. I mean, as a yoga teacher, it's actually my favorite place to go teach yoga because most of the time the people who are joining, they have never tried yoga before and they're really opening themselves up to trying something new. And I think it's fantastic that we offer services like that at GuideLink. Also at GuideLink, it's 24/7 medical assessment, so there are nurses on staff. And there's also peer services there, so peer support specialists who work talking with people who are staying at GuideLink, and it's just a wonderful opportunity for them to talk to someone who knows what it's like to live with mental illness and sometimes have been in that position themselves, either hospitalized or a patient at an access center. Okay, so some outpatient options, which probably you're all familiar with, but I just like to lay out all the options that people have for treatment. So of course there is therapy, talk therapy, and this can be done with a psychologist or a licensed mental health counselor, a social worker, marriage and family therapist, telehealth or in person. There's a lot more telehealth options now. Then there's psychiatry, which is medication management. So this could be prescribed by a medical doctor or an advanced nurse practitioner. A few other things to note. I always like to mention EMDR, which is a treatment primarily designed to treat PTSD or post-traumatic stress disorder. It uses bilateral eye movements. And then at the University of Iowa, they offer TMS, which is typically used to treat depression, and electroconvulsive therapy or ECT. And then I have a couple logos there at the bottom for some other outpatient options in our community. So there's community and family resources, which primarily provide substance use care. And then Abbey Health operates community behavioral mental health centers, which provide mental health care for anyone regardless of insurance status or ability to pay. Moving on to community-based services, so we have ACT programs, which is a selective voluntary program for intensive outpatient care. Staff come to people's homes. There's a program through the university called Impact. And then we have the assisted outpatient treatment program, which shout out to Leslie Carpenter here in the audience, who is integral to getting that program started in our community. And this is an involuntary program for people who don't know they're sick. So anosognosia, I mentioned that at the beginning, when people don't perceive their own illness. So this is also for people who are going through that revolving door of jails, hospitals, homeless shelters, et cetera. And it's an opportunity for them to get intensive case management. There's supportive community living services. So this is staff who help individuals with disabilities with activities of daily living, or ADLs. So help with them doing laundry and cooking and shopping and all those things. So getting them out in the community. And then rehabilitation programs also for individuals living with disabilities. Getting them out in the community, so some day hab programs, they go and volunteer places. I used to work up at Horizons in Cedar Rapids, and we would have a day hab group come and deliver Meals on Wheels. So they get out in the community and form friendships. And then there's peer support, which I will talk about more. So basically working with a trained professional who lives with mental illness themselves, and getting support from that person who really knows what it's like. We have the CompEAR program here in Iowa City, which connects volunteers with an individual living with a mental health condition. So the volunteer doesn't have to have lived experience with mental illness themselves, but it really helps with that isolation factor, which many people with a mental health diagnosis experience if they're struggling. They may not want to leave the house, et cetera, and so they have this buddy to go get coffee with or go to an event in the community. It's really a great program. They also started a support group for CompEAR participants and their matched buddy. And then, of course, there's support groups. So I'll talk about the ones that we offer through NAMI, but there are virtual support groups, there are in-person support groups, and this is really helpful for a lot of people just to connect with a group who struggle with similar things that they do. So youth treatment options, we do have Amy here from UAY, so she'll talk about this, some of their services in more detail. But we do have United Action for Youth, Healing Prairie Farm, which is a recent residential program in town for runaway and youth in crisis. And then the Scanlan Center for School of Mental Health associated with the University of Iowa. A few pressing issues to keep in mind. We have talked about barriers to care and stigma. So we also have a huge problem in Iowa with the shortage of psychiatric beds. So according to HHS, Iowa currently has 566 staffed adult beds and 125 staffed beds for children. However, the recommendation for best practice is 1,205 beds for adults and 413 for children based on population size. So you can see how far behind we are on that issue. Transportation is a huge issue. Homelessness, we have talked about that, and the revolving door patients, and really a lack of long-term care options as well. And then long wait times for outpatient providers, especially with Medicaid. So trying to find someone who accepts Medicaid. sure we probably either all of us ourselves or know someone who decides to take that step to get treatment for their mental health, but they call and try to get an appointment and they set someone up for an appointment in 6 months. And that's not very helpful for someone who needs and wants support right now. Okay, now I get to talk about peer support, which is really my whole life. So what is peer support? It is advocacy and guidance from someone living in recovery who has also completed formal training that provides strengths-based support to other peers living in recovery. So what does a peer support specialist do? They inspire hope for recovery, walk with people, meet them where they're at, walk with them on their recovery journey, dispel myths about what it means to have a mental health condition and or substance use disorder, provide self-help education and refer peer clients to tools and resources. We do a lot of resource navigation, and support peer clients in identifying and creating a plan to achieve their goals, hopes, and dreams. So at NAMI, we also have a family peer support specialist on staff. So this is someone with lived experience having a loved one, usually a child, with a mental health condition. So they know what it's like to live in that complex world and trying to figure out how to support their loved one. So this family peer support specialist is a trained professional. They share their experience and expertise, provide emotional support, and teach various coping skills, help connect to community resources, empower people to become advocates for their family member and navigate our very complex systems, especially for children, and help family members understand available options for their loved one. Okay, so our place. This is our recovery center that we have here in town. We are on Gilbert Street on the south side of town in Kennedy Plaza, if you know where that is. We are an entirely peer-run wellness recovery center for adults living with mental health conditions. Our program coordinator for the center, Amy, is in the audience, so shout out to her. We are a program of NAMI Johnson County. I get a lot of questions like, what is the R? So the R stands for recreation, rest, recovery, and relationships. So we pride ourselves on being a very warm and welcoming environment. We really have something for everyone. We always have a puzzle laid out. We have events. We have yoga. We have art. So we may have a particular day where we organize art activities. We display art by our very talented artists who come into the center. You can see some of it there. So we're really a safe, nurturing, non-judgmental community for those living with mental illness. We are open to any adult who would like to come in. You don't need an appointment. You just show up when we're open and get to experience some of that support. Okay, so our remote peer support program, and this is the program I coordinate, so I'm very passionate about this. We started remote peer support during the pandemic when our center, our place, had to close for in-person programming. And what we did was within a week, we called 300 people who would come into our place and see if they would want to sign up for remote peer support since they weren't able to come into the center anymore. So we called all 300 of these people, got signed up, and the way it worked is we set up phone calls for one-on-one support with our peer support specialists to continue getting that emotional support if they needed help with referrals or resources, or just to have, I always tell people when they sign up, like, this time is yours. You use it for whatever you need that day. We set up 30-minute slots, but sometimes people just want a short check-in, and that's okay. There's a lot of referral back and forth between the center and remote peer support. So typically if someone needs help applying for Medicaid or SSDI, we encourage them to come into the center since it's a lot of paperwork. But for some people who maybe experience a lot of social anxiety, remote peer support is a good option if they don't feel comfortable going into the center. or people with transportation issues, or homebound individuals. Remote peer support is a great option for them. Most people we work with over the phone, but we do offer video calls, and we now have the ability to text, which is amazing. Thanks to a grant through HHS, we've been able to expand and offer this service statewide. We've expanded our hours, and the program has just really, really grown since it started during the pandemic. At NAMI, we also offer some support groups. So we have NAMI Connection, which meets virtually on Tuesdays, and we have a family support group, which also meets virtually. And then we have a support group that, to my knowledge, is the only one offered in our state, and it's called Hearing Voices and Special Messages. So this is for individuals living with that unique experience, and it's led by peers. This is also over Zoom. And we have a new support group that meets in person at our place on Sunday evenings for people with mood disorders. Okay, a few other NAMI programs that I just would like to mention quickly. So we have NAMI in Our Own Voice, which is a program where we have peers go out into the community and give presentations about their recovery story and what it's like to be living with a mental health condition. So we'll speak to churches, student groups, really anyone who is interested. We have an ongoing partnership with the University of Iowa hospitals and clinics to go into the hospital once a month and speak to medical students who are entering their psychiatry rotation. So this has been really great. I present as part of this program, and we always get some really great questions from these students about how they can best serve during their rotation and work with psych patients who are really struggling and in crisis. So they ask about positive experiences if we've been hospitalized, negative experiences, and how they can best go through their rotation to serve these patients in need. And then we have a couple educational programs that are actually going on right now. We have peer-to-peer, which is designed for adults living with mental illness to learn about their illness, share coping strategies, just really learn how to walk along in their recovery journey. And then family to family, which is for family members with a loved one with mental illness, and learn how to support their loved one, how to talk with them, how to support them along their own journey. And then we have NAMI on campus, which we're getting going. So these are NAMI affiliated student groups. So we are working with the University of Iowa, Kirkwood, and City High to get those groups going currently. Okay. And before we go to the panel portion, this is just a picture of some of our staff at the NAMI Iowa conference, which was held a couple months ago. We have a really dedicated group of staff that are just so passionate about mental health support, and so I'm really grateful for the team that I get to work with every day. And yeah, I want to thank you all for listening. I know I threw out a lot of information, and there's about to be a lot more with our paneling opening up. But thank you so much again for being here and your interest in mental health in our community.
Thank you, Laura, for sharing your personal story and these excellent resources with us. My name is Alissa Doobay, and I'll be moderating tonight's panel portion of the evening. I am a licensed psychologist and clinical director of the Scanlan Center for School Mental Health. Our clinic offers individual counseling, group counseling, child psychiatry services, and school-based post-crisis support to K-12 students and school staff. If you have any questions or would like to learn more about the Scanlan Center, I put a flyer on the back table, and I also have my cards there if anybody would like to reach out to me. Now I'd like to take a moment to allow all of our panelists to introduce themselves and share a little bit about their role in the area of mental health.
Thanks, Alissa. Excuse me. Hi, everybody. My name is Coreen Frank, and I oversee the Office of Student and Family Supports with the Iowa City Community School District. It houses a number of programs. Key to tonight's conversation would be our Student and Family Advocate Program, our agreements with various mental health providers, our suicide prevention and intervention services, as well as our crisis response team that kind of partners with Alissa sometimes when there's incidents that occur at the school. So a few other things as well, but those are really key to tonight's conversation.
Hi, I'm Amy Kahle. I'm the Director of Intervention Services at United Action for Youth. Back in the day, I was an SFA at the Iowa City School District. I worked at City High. And I'll talk a little bit more about the programs that relate to mental health a little bit later on.
Abbey Ferenzi, Executive Director of GuideLink Center. I'm also a licensed mental health counselor. A lot of my background is in community-based mental health work, crisis work, housing support, and I think I'll probably go into more about details about GuideLink Center as we go along. So happy to be here.
I'm Drew Martel. I'm Chief Clinical Officer with Community Crisis Services. In addition to that, I'm a trainer and site surveyor for the American Association of Suicidology, and I have a very small therapy practice in North Liberty.
Thank you. I have some prepared questions that I'll be asking our panelists. And as a reminder, there are note cards in the back. If people have questions, we're happy to take those. We just ask that you go ahead and write those down, and we'll have people collecting them so we can share them with everybody at the end today. So my first question, jumping right in, is for Abbey. GuideLink Center is one of the 7 mental health access centers in Iowa. The concept of an access center is still new to a lot of community members. Abbey, can you remind us about the services GuideLink Center provides and let us know how things have been going since you opened in 2021?
Thank you very much. This February 15th, we're going to be celebrating our 4-year anniversary of being open, so happy to talk about GuideLink Center. We're one of the 7 access centers in the state. We're designated by the state and to provide immediate care, essentially, and to help coordinate both mental health and substance use services for people who are presenting in a crisis but don't necessarily need a hospitalization, but they also can't wait for an outpatient appointment. So we've been around about 4 years. I work with Abbey Health, so I'm with UnityPoint Abbey Health GuideLink Center. That's my long title. And we were contracted through Johnson County to be the managing entity of GuideLink Center. So we actually then subcontract with several other community agencies. So a lot of people don't realize GuideLink Center is the name of a building and a concept, but really what makes up GuideLink Center is all of the people and the companies that work there, providing these services in a coordinated way. So we work with Community and Family Resources, we work with Abbey Mental Health Center, Johnson County Ambulance Services, and Community Crisis Services. We have formal partnerships and contracts with them, and they provide some of the services that Laura was explaining. I also brought some brochures if you want to see more details about those services. I could talk about GuideLink all day long, but I think other people would like to talk too. And we also have formed a lot of partnerships with other formal and informal. So Laura mentioned NAMI Our Place comes out to GuideLink Center, does yoga. We have peers. We partner with local law enforcement and liaisons and crime prevention. Any ways that we can work with community partners, the hospital, and collaborate to find more ways to get access to people who really need that mental health and substance use support. And to kind of help you imagine GuideLink Center and when you or a loved one or someone you know might need it, think of it a bit along the lines of urgent care. You know, you don't need that hospitalization, and we can offer immediate care, but we don't have doctors 24/7. We can provide immediate access to that screening, assessment, and a variety of services under the building. So you can kind of think in the urgent care realm. Things have been going pretty well. We've had a lot of kinks to work out and things to figure out, but everybody stayed pretty positive, and I'm happy to say that we have admitted around almost 6,000 people to date, And definitely some of those people are repeats for sure, but, I've been to urgent care a couple times in the last year and nobody has any issue with that. So yeah, sometimes people need continued help. So we keep, figuring things out, asking for feedback. Continuous quality improvement is very important to us. We don't ever want to be finished getting better. So while we love the compliments, and we certainly get them, and I love for our staff and everyone to hear that, we also appreciate the constructive feedback and concerns so we can just keep on working on getting better.
Thank you. Drew, could you tell us a little about community crisis services, and in particular, their role in suicide prevention and intervention in Iowa? Are there any unique approaches being utilized?
Sure. So Community Crisis Services, formerly known as the Crisis Center Johnson County, provides some of the areas. So crisis services is a spectrum of care. And the idea with crisis services is typically there's not a lot of room between an individual at home struggling with their mental health and a hospital ER. And so crisis services, which really have grassroots from the 1970s, and both Crisis Center of Johnson County and Foundation 2 in Cedar Rapids have been operating to some degree since then. But so Community Crisis Services has a mobile crisis outreach team, which is a 24/7 program. There's no means testing. There's no specific criteria to qualify for the service. It's a publicly funded service, so it's at no cost to the consumer. And in most cases, the counselors can get out there in 30 minutes to an hour. The goal of that service, the goal of all of crisis services, is to provide the least intrusive intervention, the least intrusive effective intervention. And for about 80 to 90% of the clients we serve, they don't need anything more than that. So if we can de-escalate on site, that's always the goal, because that's the least traumatic, that's the least resource intensive. In addition to that, Community is one of about 300 centers nationally that's a part of the 988 Lifeline, which was, believe it or not, prior to the Lifeline was sort of a rebranding of the National Suicide Prevention Lifeline, which had been around since 2005, and then there was an even older line in the 90s that wasn't well known. In 2023, due to a congressional mandate, the Lifeline went to a 3-digit number and rebranded. It's controlled by SAMHSA, but made up of all these grassroots crisis centers, which mostly make up the system, including Community. And so Community is one of the centers that answers that line for callers in Iowa. And in addition to that, has some national contracts with the Lifeline. So is one of the centers, the national centers for individuals who contact the LGBTQ line. And is a backup center as well for chat and text, is a national center for chat and text. So 3 ways an individual can access the Lifeline services is by calling directly and then chatting or texting with the Lifeline, which seems to be more popular with younger individuals. In terms of unique kind of prevention initiatives, does anybody know how many suicides we have in the United States each year? Say approximately 50,000. So the equivalent of a Boeing 747 crashing every other day. SAMHSA and the CDC consider it one of the leading causes of death in the United States. Despite that, of the leading causes of death, it's the lowest funded. And the funding for suicide prevention would need to be tripled to come up to the next leading cause of death. So it's a underfunded public health crisis. And so lots of areas for growth in terms of research and intervention methods. Despite the field of suicidology really growing over the past 2 decades, there's a lot we still don't understand or know about suicide. One of the things I'm excited about, and that's because I'm working on this project, is that we were awarded a very small grant through SAMHSA's recently through SAMHSA's Garrett Lee Smith Suicide Prevention Initiative, which is to develop a program in Johnson County and a few surrounding counties that's looking at BIPOC and LGBTQ youth and transitional age adults in terms of suicide prevention. This is a underserved population where suicide rates, especially with BIPOC youth, have been increasing over the last decade. And it's raised several alarms at the national level. And so we're calling this program BU. It's in its very beginning stages, but I'm really excited to be working in this area. It's something that we've looked at for several years now. And so looking at minority populations that are typically underserved for a whole bunch of a lot of the barriers that were mentioned by Laura early on, stigma. There's a lot of tangible barriers like transportation, insurance, and then you have to think about things like if minority populations tend more often, a higher percent of them are on publicly funded insurance. How many providers take publicly funded insurance? How many of the providers that do take publicly funded insurance are culturally trained to work with this population, and how many of those have openings. And so when you think about that, you get down really quick to not a lot of providers. And so we know there are some tangible gaps there, and this is one such program that's looking at that. On the national level, some of the things I'm excited about in terms of initiatives, community isn't involved in these necessarily, is some of the research in things like psilocybin and ketamine use with treatment-resistant depression and suicide in particular. And there's, I think, a lot of really interesting areas of research around preventing suicide that are currently ongoing. So.
All right. Thank you, Drew. Those are some really striking statistics that you're sharing with us, so thank you for that. Amy, can you tell us about services relating to youth mental health that UAY provides?
Yeah, I can. That's a little bit of a trick question, because if I were just to talk about our kind of out-facing mental health services, I would talk about therapy, and I would talk about our LGBTQ support groups and our crisis intervention group. But actually, all the services that UAY provide are surround youth mental health. So our transitional living program for homeless youth, our kind of partner program with that is street outreach. So we have people that actually go out into the community and look for youth that are on the street and get them what they need. Our young parent program definitely has an impact on mental health. We have an LGBTQ plus program that has a support group, has gatherings. We have PrideCon coming up in a couple weeks. And then we have our youth center that's right downtown that provides a safe place for youth to just hang out around pro-social adults and do things that youth like to do in a safe space. So I think that all of our programming has an impact on youth mental health, but that therapy and the crisis services are probably the most focused.
Thank you. I'm learning so much about the different services that you all provide. Coreen, I've got 2 questions coming up for you.
Okay.
What are the primary mental health needs or concerns students are currently demonstrating in the school setting?
So I would say it matches what was shared statistically, right? Across the nation, we see a lot of anxiety concerns, a lot of depression concerns. We see the full gamut of diagnoses within the school setting, right? We have a lot of kids with a lot of different backgrounds and a lot of different needs and supports. But the ones that top the list most frequently would be anxiety and depression.
And what opportunities or services are available to ICCSD students who are in need of mental health support, and how do students access those services?
Sure. So, I mean, I feel really, really fortunate to be sitting up here because the school district's services are only as good as the partner providers that we have available to us. School districts aren't mental health providers, right, in the way that all of our colleagues up here are, but they're working really hard. We're trying to build relationships with families. We're trying to provide a safe space for kids to be who they are and facilitate connection whenever possible. So we don't house mental health services that are our own, but we have a lot of partners that work very closely with us. I mean, I saw Amy today earlier in my office. There's a couple SFAs, either current or past, in the audience. I call Drew's team, or members of my team call Drew's team on a really regular basis to get additional support when kids are potentially suicidal in our school setting. So we utilize all of these services, as well as the University of Iowa. We have some on-site psychiatric. We have some on-site therapy through some other partner agencies, Four Oaks and ChildServe. Alissa and I have regular conversations about how we can access their services and extend the reach to families. So I feel very fortunate to live in this community. That said, we're still facing barriers to access, right? Resources in general feel stretched. It feels like there's not enough for everybody. And quite frankly, not all of the services are right for everyone. So still trying to figure out what best matches a student and a family need can be really challenging. But we're here to walk in that journey and try to support as best we can.
Yeah, thank you for highlighting those community partnerships. And I know ICCSD is kind of ahead of the game, and I think connecting youth with the services that they need. So you all are doing a wonderful job. Abbey, with all of the great mental health resources in our community that Laura and our panelists, Coreen, just described as well, why are there still some people who need services but don't get them? Abbey, since your role at GuideLink Center involves increasing access to mental health care for community members, can you explain to the audience what barriers some people might face when trying to get the help they need?
Sure. And I've heard some of my counterparts here mention some of those barriers, cost, transportation, which you were just talking about a little bit ago. There's so many barriers out there sometimes when people are trying. You have to have the service available in the first place, and then when you're trying to get to it, sometimes there's a lot of roadblocks. And I think most of us are aware of what some of those might be, and maybe we've experienced them ourselves, including stigma. Sometimes people, really need that help, but they might be too embarrassed to reach out. Or if they do actually reach out and get the help or treatment that they need, then they face some criticism for doing so. So again, with all of you here today and some of the efforts to fight some of that stigma, I do believe that's helping, but it is definitely still a barrier for some individuals, some cultures, to get that help they need. But just another thing I was thinking about, even as some of you were talking, so I'm going to go ahead and ad-lib here. The other part of it is that there are some people who really, really need the help, but they don't want it. And honestly, that's one of the biggest barriers we see at GuideLink Center. We see very well-intended friends, family members, law enforcement, other individuals bring someone in because they know they need this help, but the person themselves is too sick to understand that they need it, and we're voluntary. And that is heartbreaking sometimes. That is really a barrier for people because they can't actually get the help they need, either because they can't articulate it, or like I said, they're just too sick, or their behaviors are so severe because of what they're experiencing, it's not something that a community-based center can handle. So that's definitely a barrier. We look at these all the time and work with community partners to try to address these, come up with creative solutions. But the last thing I wanted to mention too, kind of along those same lines, is you all know what it's like to feel sick, whether cold, flu, something's going on, and you're trying to call the insurance company or make the doctor's appointment or figure out your FMLA paperwork. It's really, really hard to navigate a super complex system when the thing that's hurting on you or that has symptoms is your brain. So earlier this week, I had a bout of bronchitis, and I struggled to help my daughter with her first grade math homework, okay, because I was struggling, I was ill. So one of the things is when the very thing that's affecting your health is your brain, and you need to navigate and access service, it's really hard unless you have someone there to help you. And so you tie these other things into it, stigma, not wanting the help, because I know some pretty stubborn people out there too, besides just the anosognosia, that really need it but don't want it. You really need someone sometimes to help guide you through that mental health crisis, or even if you just need basic access, because when we're struggling, that's actually one of the hardest times to know how to navigate the system. So that's why I'm glad a lot of these services are available, and that's what a lot of these services do, is help people navigate that as well.
Thank you. You bring up some really important points, and I was just having a conversation recently with some other healthcare providers talking about that difficulty in following up with mental health services, because if you go to the doctor, they say you need to see the cardiologist or you need to see, some other physician, you get a call from that office and they set up that appointment. But with mental health, there's a lot more, I think, pressure put on the individual to follow up and seek that care that they need. And so that's definitely a barrier people are facing. All right, back to Drew. As many of you may know, Iowa is currently undergoing a significant redesign of its behavioral health service system. Starting in July of this year, Iowa will be implementing a new statewide plan that is focused on ensuring equitable access to prevention, treatment, recovery, and crisis services. Services will be locally coordinated within 7 behavioral health districts, with Johnson County being part of District 7. Drew, what impact might this redesign have on providers and consumers in our community?
I wish I hadn't put this question in here. Suddenly you regret the decision. For those of you that have been familiar with the system for a while, so when I started kind of as a baby in the field, it used to be a county-by-county mental health system that we had. So you had a central point of coordination, a CPC, you had county social workers. This is pre-2014. Then in 2014, the state overhauled the system into the mental health regions, the MHDD regions that we've currently had since 2014. We're in the East Central region. Last legislative session, We are now moving, the legislature and governor are now moving the system to these behavioral health districts. And what's happening is essentially the state, through HHS, is taking over funding of the mental health system. In the regional system, it was coming through, I believe, mostly tax levies, and then there were some federal funds and stuff that were getting tied in. In the new system, those funds will be dispersed via a private party. The Iowa Primary Care Association won that bidding contract and will be the kind of entity that contracts with individual providers and divvies up this lump amount of money that the state's going to give them. I don't think we know what that amount of money is. But it is safe to say providers across the entire state are very, very anxious about where this is going and what this looks like. It's a huge flipping of the system. I don't know if it's good or bad. I don't know if it'll be a better system or not. I'm always somewhat skeptical of changes to systems, just in general, but that doesn't mean that it can't pan out. It's really hard to say what this will mean to both consumers and providers. And this is also in the context of, what was it like, maybe 6 years ago, we also privatized the Medicaid system in Iowa, right? And that was pretty disruptive. We had providers come and go and come and go and come and go, and it was a pretty big transition. I anticipate this will be an equally big transition for consumers and for providers. At the same time, the regional system wasn't perfect. There were a lot of issues with the regional system, and one of the big critiques of it is that things were very siloed, that you had to go through multiple doors to access services, or you had to go through separate doors to access services that you need. I am hopeful that when the state says one of the goals here is to kind of get rid of that siloing, I'm hopeful that happens, because people shouldn't have to retell their story and retell their story and retell their story, and they shouldn't have to go to 10 different providers to get access to different levels of care. That's the best answer I have right now without talking myself into trouble or something like that. There's still a lot of unknowns because it's last I know, the actual funding amount, the state hasn't actually said what the funding amount is going to be. I assume it'll be hundreds of millions of dollars because it's the entire system. But none of us know what that'll look like. And that will be probably the biggest thing in terms of what services continue to grow, what services no longer exist, right? In the mental health system, why services come and go is the reappropriation of funding. And so this will be a big point in the story of Iowa's mental health system. I'm going to crawl out of here now.
No, I appreciate you taking on that challenging and technical question, helping us understand how the system of mental health works in Iowa. Coreen, when our kids have unmet needs, we often turn to our community experts in education and healthcare for support. This holds true for youth mental health, where we need strong community-based partnerships that include our school systems to address the varied mental health needs of our youth. How can schools collaborate with parents, healthcare providers, and community organizations to support students who might be struggling with a mental health concern?
Sure. So I was trying to think of some concrete examples, right, of either things that are in practice or things that can be done. I think the first one really is communication. So figuring out as a parent who's a trusted member of the school team that you're willing to have a conversation with. Doesn't have to be your student's teacher, could be a counselor, could be, in Iowa City schools we have student family advocates, which play a really unique role to extend the support that we have for our families. Could be a building administrator. But that initial conversation and establishing a relationship with somebody that you trust to help take care of your kid when they're out of your care is really important. And kids spend a long time at school. So there's a lot of adults there to choose from. So my first suggestion would be figure out who you trust enough to start to share your story. And it doesn't have to be everything at once, but start to figure out where those relationships land that really support you and your family. Second to that is, as we move through really connecting families and trying to find resources and establish bigger support networks, is releases of information. Because all of us at this table are only able to share when we have that permission from you, either as the individual or as the parent of that child. And that's really, really critical, right? So we want to protect you as parents and guardians and kids, and we also want to do our best to collaborate as teams to be able to work together to sometimes solve some really complex needs and complex issues that are occurring with our families. And then the other thing that we've tried really hard to do at Iowa City is to promote education and information for all. So we've built out some websites that can act as a hub. All of our secondary students and staff members on the back of our IDs, I'll do a little example, have a QR code and a website that's listed. And that'll take you to a support page on the district's website that has links to all of our student family advocate contact information, all of our school counselor information, all of our school nurse information. Those are team members that are going to have extra training and support to support families. It has a link to Care Solace, which is a broker service to help families get connected to therapy providers. We can help with that, but you can also look on your own if you're not at the point that you want to have a conversation yet with somebody at school. We have all of our community partners connected in that as well. So at the very top, you're going to see 988, you're going to see mobile crisis, because that's something we promote really regularly with everybody within our system. So I think start that communication where you're comfortable, what you're comfortable. You get to own your narrative for your kids and your family, but figure out a way to start building that network of support, which likely will include many of these amazing people in their organizations. So that would be my starting place.
That's some great feedback and thinking about, in healthcare in general, but really even more so in mental health, that privacy is key. Yet we need those opportunities to collaborate and communicate in order to really serve students. So taking that time to fill out those releases. I think it also goes to what was said earlier about autonomy and mental health. We really look to clients to have autonomy and make choices about whether they want to seek out different services and supports. And so for outpatient services, that autonomy exists. And that can be a challenge, but is an important part of how we view humans as being able to make choices for themselves. So we hope they make choices that allow us to communicate and work together so we can help them. Now, Amy, how does UAY work with community partners, since we've been talking about community partners, to provide prevention and intervention services?
We work really closely. UAY is pretty amazing. I love it. We do great things, but we don't do everything. And so we have to rely on our other amazing community partners to help us do the things that we are not maybe as educated on. So I just did a quick list when I was waiting here of all the community partners we work with, Monsoon and NISA and the Johnson County Attorney's Office and DVIP, RVAP. We work with anyone who's willing to work with us to best provide the services for our young people and their families. So I should have said that before. We work primarily with young people, but young people have families. And a lot of times that conflict that young people have surrounds their families, right? So I talk to parents all the time on the phone. I have a 16-year-old who's out of control. What do I do? We're constantly problem solving and looking in the community, where's the best fit? So we're kind of this one-stop shop for young people, and then we refer out when we need to our community partners. We're looking for that warm handoff. And we have so many points of entry at UAY. You might know UAY from the youth center. You might know UAY because you're a homeless teen. You might know UAY because you saw me at City High doing crisis work, right? And so if you know one person, if you know Kahle at the youth center, and then all of a sudden you need a therapist, come on over to UAY. I know Kahle, he's from UAY, he's cool, maybe this therapist will be cool too. So we do warm handoffs a lot within our organization and then with our community partners as well.
That's wonderful. I know that.
But ROIs are really important.
They are, right? ROI. And sometimes they're complicated. Just like talk to someone,
Ask
they'll help you fill it out.
questions.
The number of times we have to fill those out is a lot because they're complicated. Okay, we have one more question for Abbey. There are a lot of misconceptions about mental health services and the people who face mental health struggles. Abbey, can you expand on this and explain why it would be helpful for our community members to know about these misconceptions?
Sure. I think it's helpful to discuss the misconceptions and address them because they're one of the reasons that people don't get the care that they need. There are a lot of misconceptions out there. I'd like to think maybe I've heard them all, probably not. Nothing that we could possibly go over in this amount of time. But a lot of it comes back to people either not understanding the service, what it means, or what it means if they have a behavioral health issue that they need help with, meaning they think there's something wrong with them. You've heard a lot of the negative terms, crazy, go take your meds, something like that. It all has a lot of negative connotation to it and a lot of judgment associated with it too. So people who receive behavioral health care, meaning mental health and substance use services, they're accessing health care. A lot of times I reframe behavioral health care to health care because it's just as important as the medical care that we receive. And the more we start addressing behavioral health needs with more parity to medical needs, I'm trying to think here of an example. If someone needs prescription lenses, nobody's questioning if they're crazy or there's something wrong with them or what did you do? What did the parents do? No. There's something that they need fixed in their vision. There's something missing or something they need added. Same thing with if someone is insulin dependent diabetic or other things. I mean, there's medications, there's treatment that people need, and the same thing happens in the medical community, but yet these individuals aren't faced with the same amount of scrutiny. And behavioral health typically doesn't get the same amount of recognition, value, or funding in order to treat it just as well as we would a lot of the medical diseases. So just kind of highlighting some of the misconceptions because I think people sometimes think behavioral health services, whatever they are, for those people, they're for all of us. They are absolutely for all of us, and we want to take care of our mental health just as much, and we want to pay attention to it just as much as we would our physical health.
Thank you so much. We are ready for our question portion, so I see some cards possibly coming this way.
Yes. Okay. We have a couple questions already, so I will hand those off to Alissa, but our staff team is coming by with cards for you if you have any more questions to write down. You can just hold them up or pass them to the end of the aisle. We'll grab those. And folks in the back, we've got some more for you as well. So make sure you write your questions down. We'll come and get them, and Alissa will make sure if we've got duplicates, we'll ask them once.
Thank you.
Yes, it goes.
All right, the first question is for Abbey. Would you address HIPAA and that medical professionals can always listen to family and friends? That two-way communication is allowed to keep a kid safe.
Yeah, so allowed to keep a kid safe and honestly anybody safe. HIPAA is there. I'm a fan of HIPAA. I remember when it was all rolled out. What was that, 15 years ago? Of course, to protect people's privacy and their private health information, for sure. But that doesn't mean that we can't have care coordination between providers, family members, at least basic care coordination, especially in an urgent or emergent situation. For an example, if I have somebody call me and I can't disclose whether or not that person is at GuideLink Center, that doesn't mean I can't listen to what the person is going to say and take that information and do some of that basic care coordination. In fact, I welcome that collateral information because honestly, family members and other individuals get to see people in their own spaces and spend a lot more time with them than I ever could. So while it's really important to follow the rules of HIPAA, and we do, and to get those releases of information absolutely whenever you can, I think basic care coordination, and especially in urgent and emergent situations, is really important. So not sure who asked that or if I answered your question fully, but that's what I got.
Great. Our next question, since opening GuideLink, how has this helped law enforcement and emergency room access for the community?
Sure. So we are about a 50% ER diversion rate at GuideLink Center, meaning about half of the people that come to GuideLink Center tell us that they would have otherwise went to the emergency room. Law enforcement continues to be one of our top referral sources, and most of the jail diversion that we do with law enforcement is typically around like public intoxication. Some other individuals with more severe behavioral type needs, I cannot even pretend to say that that's something that we can handle at GuideLink Center, being involuntary and with the resources and space we have. But there definitely definitely is some jail diversion going on, ER diversion, and we've seen through, again, a lot of those community partnerships and efforts, and I would say a lot of people going above and beyond. We're pretty special in this community and in this county, and a lot of people believe that individuals who have these issues, mental health, substance use, they want to see them get treatment. They don't want to see them in jail. They don't want to see them inpatient if they don't need to be. So I think it's a lot of people working together has helped us see those outcomes get better and better.
Great.
It's hard for me not knowing who asked the question, so I'd be like, is that enough?
Okay. What's the best way to describe our place? Who goes there? What do they do? What are the hours? All that kind of information.
Yeah, great question. So as I mentioned, we are open for adults, so anyone 18 or older, anyone living with a mental health condition. We are extremely low barrier, so when you walk in, we have a sign-in sheet. You put your name down, and then for your first time there, we have a safety contract. That's just a very short document agreeing that you won't come in intoxicated or violent or anything like that, and then everything is free. So you can come in. We have a very diverse group that comes in, a variety of diagnoses, a variety of backgrounds. I think that part of the question was hours. So we're open Monday through Friday, 1 to 5 p.m. As I mentioned, you don't need an appointment. You can just walk in. We try to do, someone was talking about warm handoffs earlier. We try to do as much of that as we can. So for example, when we have one of our peer support specialists who goes over to GuideLink, and that staff member has the opportunity to talk to people about our place and even say, hey, I'm going to be there on Thursday, because it can be kind of hard to go to a new place if you don't know anyone. And so those warm handoffs are really great. We're also doing that with our work in the hospital, talking to someone there and then making sure, that staff member is there on that particular day. So very diverse group. Keep it open to anyone who wants to come by. If you're just a community member who's interested, we would love to see you. Come by anytime. We're welcoming and open to everyone.
Thank you. Have you seen an increase in training regarding serving people with disabilities and mental health struggles? So that co-occurring population.
So was the question disabilities and...
Yeah, and the question's for anybody, but people who have disabilities and mental health issues.
Yeah, so at our place, I wouldn't say I've noticed an increase, but we definitely do have individuals we serve, especially I'm thinking on the remote peer support side, who live with intellectual disabilities as well as a mental health condition. As far as substance use, right now at NAMI, we don't have any peer recovery coaches on staff, so that's a trained professional with lived experience with a substance use disorder. But we do a lot of referrals. And of course, if you are dual diagnosis and have co-occurring disorders, you're welcome to receive services from us. So that's where we're at with our place.
I would just add that I think a lot of us at GuideLink Center and other providers have seen additional co-occurring disorders, not just mental health and substance use and of course intellectual disabilities, but also medical conditions. Mm-hmm. I don't know if you've heard the stat, people specifically with severe mental illness typically die 20 years earlier than the average population. So oftentimes if you don't have your mental health symptoms in check, there's no way you're taking care of all the physical ailments you might have. So we do see that. We try to manage it the best we can, certainly put referrals in there, but I think there's a lot of work to be done to managing some of that co-occurring, the issues that come up.
Yeah, I would just say that I've seen with some of my colleagues in the hospital a movement toward understanding how to really integrate the developmental disabilities with the mental health in the treatment, because I think for a lot of times it was medicalized in a very separate way. You have your developmental disabilities and you have your mental illness, and not recognizing how those things can interact and how treatments might need to shift to address the full needs of that individual. So I think that that's an area that's continuing to grow.
I think too in that realm, one of the areas that we have seen growth in is integrated care. And so where you now can find some places that have medical staff, mental health professionals, and even like holistic healing on site. And so there is some movement towards more integrated care rather than you get your substance use condition treated at a substance use provider, the therapist does mental health, the psychiatrist does at a separate location, and then of course you have your medical provider, and none of them are communicating. And so there is a movement towards integrated care that I think is a positive one in that regard.
There's a question I think is really important for us to discuss. So there's a question about whether or not it's safe to ask people if they're thinking about suicide if they don't bring it up.
Yeah, and there's two ways I recommend. I always tell people there's two easy ways to ask about suicide. One you can call normalization, and I'll do something like this. Because this comes up in therapy too all the time, and I know therapists that are like, well, I need the right amount of evidence to ask about suicide so they don't become mad at me or I don't do something wrong. And so I like these two approaches, which I always train on, and one is normalization, and that's where I say like, hey, I've had a few friends who went through a divorce. A couple of them said they had thoughts of suicide when they were going through a divorce. I wonder if you are. And so I'm saying, if you are, it makes sense. And if you are, I'm willing to talk about it. And if not, it usually doesn't elicit a defensive response. The other one is called attenuation. Does anybody know what it means to attenuate? I didn't know until I knew. It's a really pretty word, and it means to like soften or dampen. And so with attenuation, this one is really applicable with any situation. I'll just say something like, hey, with all that you're going through this last week or this last month or this last year, I wonder if you've had thoughts of suicide. Again, if you have, it makes sense. And if you have, I want to talk about it. There is no research that shows that by asking about suicide or talking about suicide, you put the idea in someone's mind. And if you are aware of research that shows that, send it to me and I will laugh at you. Laugh at you and where you get your research from. No, actually, and the opposite is it's the belief is that part of the reason we have such a problem with suicide in the United States is because for so long it was taboo. And the history of suicide in the United States is horrific and interesting at the same time. It was criminalized at times. It was over medicalized at times. And as I mentioned earlier, and the funding for suicide prevention and research has started to trickle upward, but it's still significantly lower than other leading causes of death. And it's a major public health crisis. And so if you're worried about someone, and if you're not comfortable asking, find someone that can. But again, those two, normalizing or attenuation, rarely elicit any type of defensiveness. And if the person says no, I say, okay, thank you. And we talk about something else.
I just want to add, he's the expert, but I wanted to add that in some of those moments when you do ask somebody, because it is intimidating sometimes. I've been a therapist for a long time and working in this field a long time, but it's hard, professionally and personally, to ask somebody that. But I will say my experience for the most part has not been met with defensiveness at all. In fact, there's some amount of gratitude and honestly relief is what I've seen on people's faces before. They might put their head down a little bit and say yes, but you almost see the shoulders go down a bit. Like it's like, thank you for asking me that because I probably wasn't going to come out and say it myself. So just wanted to share that on a personal note.
Yeah, I teach youth mental health first aid, and one of the things that we do is turn to your partner, ask them if they're thinking about suicide, and it's even awkward in a kind of a clinical setting, right, where we're in this classroom learning about mental health. So it seems silly, but it's a great idea to practice it with somebody safe, because I've had to ask it 1,000 times. It's never easy, but it gets less intimidating the more you do it.
And it's important because what we know about suicide in terms of kind of the leading risk factors, there's two that really stand out. One is what's called thwarted belonging, and that is people who die by suicide feel like they don't belong. They don't belong to a family, a community. They don't feel connected. Oftentimes we see people who have a caring support network around them, but they feel alone, right? And there's a difference between feeling lonely and being alone, and that's important in the world of suicide. So we have this thwarted belonging. I don't feel connected to the people around me. And then the other risk factor that's really interesting is perceived burden. And this is interesting. People who die by suicide often feel like they were a burden to their loved ones, friends, and families. And this is interesting because I do a lot of panels, and I have family members come up to me and they say, like, my loved one died by suicide. If they knew how much pain they would have caused the family, it was selfish. And I understand why they feel that way because it's devastating to them. But in letters of those who died by suicide, and there's been significant studies on letters left by those who have died by suicide, they often say, I was a burden to my family. I'm doing this on behalf of my family because I've been a financial burden to them. My mental health has been out of control for years, et cetera, et cetera. And so when you engage a person you care about in that conversation, hopefully you're also connecting with those aspects, those risk factors.
I also just need to give a shout out to the ASSIST training that community hosts. So if you are somebody who just wants to learn more about how to even have those conversations or understand them, and Drew, maybe you can share, but it's a free training. You offer it about monthly-ish, open to anybody. It's a training that we send our team members to just get that additional information and additional training. And many of them have a clinical background, right? Or studied social work or something like that. But it's just it's a lovely training, probably one of the most powerful ones I've been to.
I agree.
It is considered the gold standard training in suicide intervention. There's also, so that's a 2-day training. Safe Talk is more of an introductory level. It's a 4-hour training, but put on by the same organization, Living Works. So those are really good things to seek out if you want to know more. I'm going to ask this question because it kind of is in the same vein. It relates, but as panelists, can you also address the removal of means as an important way to prevent suicide?
Yeah, this is a really delicate this is a more delicate conversation, and the reason for that being, does anybody know what the leading means of suicide in the United States is? It's firearms, and firearms make up about 50% of all suicides. And the other thing I tell people is, kids die with guns just like adults do, and kids often die by suicide using a family-owned firearm. And so, one of the most effective ways to prevent suicide is by removing the means that a person identifies. It's really interesting in research of people who have survived near lethal suicide attempts, somewhere around 50% will endorse that between the time they decided to end their life and took action was less than 5 minutes. And so if they don't have access to that means in that 5-minute period, very well might prevent a suicide. And so we even say things like, would you store your ammunition and guns separately? If you are, could you disassemble your firearm? Could someone hold it for you? And so any conversation around building time and space, and it doesn't have to be, can you get the firearm out of your house? That's where it becomes delicate. That's where people can become defensive, and our goal is not to elicit defensiveness. And so the conversation is, what steps can we take here in your house so that there is more time and space if you decide to end your life and your access to means? Very important conversation. There's a really great training out there. I think it's an hour or two called Counseling Access to Lethal Means, or CALM. It's provided for free by the Suicide Prevention Resource Center. The Center for Behavioral Excellence does it as well. And it really has some great prompting. The VA has invested a lot of resources because veterans own firearms at a higher proportion. But you can also do it with things like medication. You can do it with things with other mechanisms of suicide, but it is probably the most effective way to prevent a suicide is limiting access to the identified means. And again, we're just looking at buying 10 minutes, 15 minutes.
And a lot of people don't think of it. I would echo everything he said, but people don't think of it. If you're talking to family members, and sometimes I will say, or I know counselors will say about any kind of guns or anything in the home, and they're like, oh, if you can't, I've said this before, if you can't do anything else, like if you're stuck, get any firearms out of the home. Do that first, get them out of the home. And it's surprising how often people don't think about that, but you're exactly right. It's the most lethal means. If someone's impulsive, especially children, and they can get that quickly, that's definitely why it's so important to remove those means and any other means that someone has named, but specifically firearms because of the lethality. So. Yep,
and that's exactly it. And we know that when people attempt suicide, not infrequently do they try to back out. And so if you overdose on prescription medication, you can still call 911 or go get help. The problem with firearms is there's no backing out, and that's why the lethality is so high with them. And again, I can't state this enough, we see the same trend with youth. It's not different. And so if you have a youth struggling with their mental health and the parent has a firearm in the house, the risk goes up a lot. And so it's a conversation worth having as a professional, or if you're comfortable having that conversation with a loved one.
And I have to throw this in there. I don't want to cause any controversy. Every once in a while I've been met with like, oh, is this anti-gun talk? No, I'm anti-death. And please, that's why I'm saying this. I'm not talking about your rights or anything. I'm just saying if this is in your home, and your loved one's struggling, and you don't want them to die, this would be a really good idea. So, because I have been met with that a few times.
So there's a question I've been trying to think about how to ask exactly, but I think it's also important to talk about a little bit. So there's a question of what happens when you reach out for resources and they don't come through. So for example, this person talked about trying to reach out for mobile crisis and them not arriving. What is the next step? What can people do when they're in that crisis?
I'll answer this one too, I suppose. That's a tough situation, and if that happened, I'm genuinely sorry that happens. There is no perfect referral out there, right? That is the challenge of the system. Counselors are a finite resource. Mistakes do happen. In regard specifically for mobile crisis outreach, what I would tell someone to do is to call the crisis line back and let them know, and the counselor would absolutely follow up on that and try to figure it out. And I understand that for a person who's experiencing a mental health crisis, that's asking a lot. There's a larger concern here, I think, across the system, not just in crisis services, and that is that referrals are rarely tailored to the individual. And one can see, like, the person walking out of the office with a handful of pamphlets for services that they may be qualified for, they may not be qualified for. There's such turnover in services anymore. Some of them might not even exist anymore, or you show up and you find out you're not qualified for it. It's a huge issue. When we talk when I do training with our counselors, like, the golden rule is you do not give junk referrals to people, and it still happens, and it happens for a whole host of reasons. But as it relates to crisis services, I would immediately go back to the 988 Lifeline is what I would tell someone to do, because that will be answered. There is no scenario in which the 988 Lifeline isn't answered. If the Foundation 2 doesn't answer it, it rolls to community. If community doesn't answer it, it goes to every center in the United States who will pick it up first. And so that is the quickest route to accessing someone. For the larger issue of junk referrals, that is just an issue that plagues the mental health system. I'm sure there are many people here who are familiar with that, and many providers are guilty of that sin.
Yeah. And I would add that some of it is that provider shortage. There's, as we talked about the beds earlier, there's not enough mental health providers for the need that's out there.
I was going through our wait list the other day, and I came across one from July that I'm just getting to now, because we have an opening with a 3 full-time therapists, but 70 on our wait list. It's just, and it's hard because you don't know who to refer them to, who does have openings, who doesn't. So it is so hard. Keep calling back. I would just keep calling back. It's tough.
Can I add one thing to that?
Yeah, please.
And I also think this is, I think that's one of the unfortunate things, the loss of county social workers that we used to have. I used to be able to drive in 2013 over to our county social worker, be like, hey, I'm working with this client who has really complex needs, and they knew locally how to work the system. Mm-hmm. They are basically all gone now in the way that we've changed the system. And so even for providers, if we have a complex case, there is no one showing up to save us, to tell us how to coordinate that case or where the appropriate access point is. You're kind of left to fend for yourself. And that really is the unfortunate thing of the loss of localized county and state funded kind of mental health coordination that we used to have with the CPCs. That was a major benefit. And you knew the county social worker because they'd been doing it for 270 years. And they were like, oh yeah, I know so-and-so here, and I'll give them a call and I'll hook you up. And that's gone now for the most part.
Do your organizations take volunteers? We've got people interested in getting involved.
Yes, we definitely do at NAMI. Absolutely. Contact me. We have our brochures there in the back. So we have volunteers at the NAMI office who help with administrative things. We have our annual NAMI walk, which happens in May. I hope to see you all there. It's always at Terry Trueblood. And so we have volunteers helping plan that event. We have internship opportunities. We have some great social worker students who are interning with us this year. And we're really open to any other interests you may have. So feel free to reach out to us. We're always looking for volunteers.
Yes, for community.
Okay, it's complicated because we have several companies that work at GuideLink Center, and individual companies have their own volunteer policies, protocols. Overall, I don't have a volunteer program, which is something we need at GuideLink Center. It's on my to-do list, but we do have students, interns. We've done some job shadowing and whatnot. So it's all I can say to excuse myself is it's difficult to figure out with several different companies how to make it work.
At UAY, we don't have a volunteer coordinator, so again, that makes it a little bit difficult, but we do have some big events like PrideCon coming up, ParentCon that we could use volunteers for, and then our Young Parent Program, we do weekly groups, and sometimes we need someone to watch the babies, which is always fun. I'm always first in line for that. And so there is some kind of specific needs, and I left information on the back table too, and you could always reach out to me or go to our website and find out. I think there's a volunteer button there. There might not be.
But there might be.
It'll be a surprise.
As you probably would have guessed, we have a whole application and background checks that have to be done in order to volunteer at the school. So I would really, really support you volunteering with these amazing agencies as a first step and an easier access point, because volunteers are so critical. We have a handful of programs that take them, but it's just a little bit of a different structure.
We have reached the end of our time, so I apologize. There's a couple of questions we didn't get to, but thank you.
Yes, everyone, thank you so much for your engagement. Can we please have a round of applause for our providers? The mental health resources that we have available in Johnson County are only as robust as the providers who are willing to have this path be their career. So thank you all so very much. As we wrap, I do want to give a quick shout out and thank you to Sheriff Brad Kunkel, who is here. Thank you for attending tonight. I know law enforcement plays a critical role in getting access to care for individuals when they are in crisis, so thank you for your engagement. We greatly appreciate it. Again, we know we just scratched the surface, but please take some additional resources for you and family members, and know that you are a member of a caring community. We like to say that we know that Johnson County is the very best place to live, give, work, and play. I think we're going to add that Johnson County is the very best place to live, give, work, play, and care. So thank you. Thank you all very much for coming tonight.